Our next speaker is Dr. Andrea MOLINARI. She's the Director of Fellowship in Pediatric Ophthalmology and Strabismus at the Fundación Metro Fraternidad, I hope I get that right, in the Central University of Ecuador. She is the president of the International Strabismological Association, a great and fantastic strabismologist. She'll be speaking to us on strabismus and myopia.
Thank you, Dr. Saxena, for having me in this session today. And I'm going to talk about strabismus and myopia again, but something different. So because when we think and we talk about strabismus and myopia, the first thing we think about is these cases of huge eyes and this type of strabismus. But actually, and I don't have financial interest to disclose, actually, there are a wide amount of strabismus types that can be seen in patients with myopia that range from infantile, associated to prematurity, acquired esotropia with divergence insufficiency, the acute acquired comitant esotropia, Bielchowski type that was already mentioned this morning, sensory strabismus, and of course the one we just talked about in the previous session, the one associated to staphyloma and muscle path displacement. But how frequently can we encounter strabismus in patients with pathologic myopia? And one of the largest papers on this topic is the one published by Dr. Tanaka and co-authors at the Medical and Dental Tokyo University, who looked retrospectively into 636 high myopic patients from his myopic clinic. And they found that almost 20% of their patients suffered of strabismus. Of course, because it's done in Asia, in Japan, most of them were exotropic, which is not our situation in the Western Hemisphere, and almost 5% were esotropic. 16% of these patients also had vertical deviation, and in 2.5% of their cases, they found of strabismus fixus-form. What type of strabismus is more frequently seen? And this depends, of course, on the part of the world you are working. For example, in the previous paper, you have seen that the exotropia was the most frequently one seen. But that's not what we see in the Western Hemisphere. And in the last International Strabismological Association meeting in Cancun, Mexico, we presented this paper where we looked into the clinical characteristics of our patients with esotropia and high myopia, and we evaluated the outcomes of the patients undergoing surgical correction. This was a retrospective study done between the year 2000 and 2022, where we only found 26 patients with esotropia and high myopia, with this mean refraction almost equally in sex, and most of them were children. You might ask yourself, especially living in this part of the world, only 26 patients in 20 years. But I come from this country, that's where I work, in Quito. We are right at the equator, and we live at 3,000 meters high. If you look at the Finnish meteorological webpage, where they explain in some parts of it the UV index forecast, and this is the UV exposure in different parts of the world, you will see that in Quito, the city where I work, at a certain day, at midday, we reach 15 UV index in a scale that goes from 0 to 17. Above 3, skin and eye protection is recommended. In Washington, D.C., the same day, at the same time, they only reach 5. So this, together with our genetic pool, makes that the prevalence of myopia is very low in our population. Of course, this is also changing as in the rest of the world. But in a study that we did in the year 2000, on over 6,000 children that we screened, we only found a myopia prevalence of 2.6 and high myopia of 0.16. So as you can see, our population is pretty different to the one you're used to see here. So among these 26 patients, most of them children, we found 8 patients that started their strabismus before the age of 1 as an infantile esotropia. 10 patients, 10 of those patients were born premature, and 4 received laser treatment for retinopathy of prematurity. The amount of deviation was very variable, between 15 and more than 100, but most of the patients had a deviation between 30 and 45 prism diopters. 8 patients had displaced muscular path, as we talked this morning. This is one of them, one child of 18 months of age. Of the 26 patients, 19 were operated, and in 13 patients, only 1 surgery was done. 3 patients received 2 surgeries, 1 patient 3 surgeries, and in 2 patients, 4 surgical procedures were performed. This is interesting. Only 10 patients had a good result with 1 procedure, 10 prism diopters or less, which makes that we only had success with 1 surgical procedure in half of these patients. Which surgical techniques were utilized? In 13 patients, we did a resect or recess plication procedure, and in 6 patients, we did muscle relocation procedures. In 3 cases, we did the zigzag technique, elevating the path of the muscle. In 3 cases, we did a Yokoyama technique, but one of these cases had a previous zigzag technique done, and in 1 case, we did a Emmy Jensen technique. So what type of esotropia can be found or we found in our cases? 8 cases presented as a form of congenital esotropia. We found 2 cases of sensory esotropia, and in 16 cases, the esotropia was acquired. Some of the cases had more than 1 etiology or 1 cause. And let me finish my presentation describing one of these cases where we had multiple causes. We found multiple causes for her esotropia. This patient presents to me for the first time at 8 months with the history that she had esotropia starting the first months of life. She had an esotropia of 60 prism diopter with what I thought at that time only a right inferior oblique overaction. But what was peculiar at my examination is that I found this cycloplegic refraction at 8 months. So my first surgical procedure on her was a bimedial rectus recession with a FUN and anteriorization of only the right inferior oblique. Postoperatively, she had a residual esotropia of 15 prism diopters with, of course, deviation also, overaction also of the left inferior oblique. 1 year later, the esotropia increased to 20 prism diopters. This is why I performed a second surgery consisting of a resection of the left lateral rectus of 6 millimeters and anteriorization of the left inferior oblique. And so 1 month post-operative of the second surgery, she was orthophoric but for near and distance, and we were very happy. But I kept seeing this patient, the myopia kept increasing. She was not very compliant with the left eye patching, so she had an amblyopia on her right eye. And 13 years later, when she was 15, she comes back with a recurrent esotropia of 35 prism diopters. You can see that the myopia kept increasing. And I performed a third surgery. I didn't have images of this patient, but I could see during surgery that the lateral rectus was inferiorly displaced. So what I did is I elevated the right lateral rectus after resecting in 5 millimeters, and I also elevated the previously resected lateral rectus. So she had 3 surgeries. And now she had a residual esotropia of 15 diopters, but she was happy with that, so I was happy also. But she comes back 10 years later, 20 years now, and she had a recurrent esotropia for distance and 20 prism diopters for near with an axial length of almost 30 millimeters. Now I could obtain the images. You can see that the lateral rectus were not displaced, but remember that I already elevated those lateral rectus with a non-absorbable suture. But you can see that the superior rectus were nasally displaced. And this is why you will see that when she looks up, you can see, especially on the right eye, how the eye, when it goes up, it goes in, because the superior rectus is acting more as an adductor than as an elevator. So in this case, what I ended up doing, this is the superior rectus, I placed a suture, non-absorbable suture, 8 millimeters back from the insertion, and then here's the previous suture of the Mercian suture I placed on the lateral rectus. So I passed the suture next to this suture, and then I pull, this is the lateral border of the superior rectus, and this is the superior border of the lateral rectus. And with that, the patient was orthophoric, and when looking up, the eye did not go in. The question is now for how long, but now if she comes back 10 years later after, I probably will be retired, so this will not be my problem any longer. So to conclude, the strabismus in high myopes are more frequently seen than in the general population. General population up to 5%, in these patients up to 20%. Esotropias associated to high myopia can be due to different causes, as you have seen in this previous patient. First as an infantile esotropia, then as a sensory esotropia, and then she had also the muscle paths displaced. Management can be challenging. The success rate with one procedure is lower than in other forms of strabismus, and it can be recurrent, as in this patient. Surgical complication as scleral perforation is something that you have to consider when operating these patients. If no displacement of the muscle path, resect procedures are very suitable for these cases, but if significant muscle path displacement is present, muscle relocation must be considered in order to obtain the better results. So thank you so much for your attention, and please remember this ISA meeting in Buenos Aires next year.
Thank you, Dr. Andrea. Any comment or question? Just a question, Andrea, if you have a child who comes with esotropia and has myopia, so would you consider imaging to see muscle displacements, or you would plan your conventional surgery?
Like this one with 8 months?
Yeah, a child, an infantile, a possibly potential infantile esotropia.
I don't think this child, the one I presented, had muscle displacement at 8 months. Although in my previous talk this morning, I presented an 18 months a boy that had muscle displacement even at that time. But I wouldn't. No, I would not. But surgically, maybe you would like to see the muscle if it is displaced or not.
And one more question. So if we image a child with esotropia or any patient with esotropia, there would be a certain amount of nasalization of the superior rectus because the eye is inwardly deviated, and so depending upon where you're taking the cut or the cross section for the coronal image, you are going to have a little bit of nasalization. So how would you, like in this case, how would you, the lateral rectus was operated, so there was not significant downward displacement. So how would you grade now the amount of nasalization of the superior rectus?
Well, but you can study the movement, the eye movements, as you saw in this girl. When she looks up, the eye went clearly in. So you're right. There is a certain nasalization of the superior rectus normally, especially where the cut is. But you can, better criteria is looking at the eye movements.
Right. So motility is still extremely important for us to be able to.
The clinic is always sovereign.
Right. Thank you.